All right, folks, it is the noon hour, and Veronika, as you probably are well aware, people will trickle in, as folks transition from their previous meetings and grabbing their lunches. So it is a great pleasure to introduce Dr. Veronika Mesheriakova, who cares for adolescent and young adult patients and specializes in the treatment of substance use disorders and addiction in youth. She is the director of the UCSF Youth Outpatient Substance Use Program, USUP, the UCSF Youth Addiction Management Training Program, and assistant director of the UCSF Adolescent and Young Adult Medicine Clinic. She earned her medical degree from the University of South Dakota, Sanford School of Medicine, and completed a residency in pediatrics at Yale New Haven Children's Hospital, followed by a fellowship in adolescent and young adult medicine at UCSF. She's also board certified in pediatrics and the subspecialty of adolescent medicine. Please join me in a warm welcome. Thank you for being here today. Excited to hear your talk, and take it away.
Thank you. And I'm so excited. I also added a new board certification in addiction medicine just this past week. So I know, I'm very excited about that. It was fun. Okay, so thank you so much. I'm so happy to be here with all of you. Today's talk is going to be, it's going to cover a lot of topics. So everybody hold on to your seats. Hopefully we'll learn a lot, and we can delve in further, hopefully in other venues. So let's jump right in. I'm hoping that after today's talk, all of you will be able to talk passionately about why addiction is a priority for providers who work with youth. Talk a little bit about neurobiological and diagnostic considerations for addiction, especially in adolescents. We'll talk a bit about epidemiology and the trends in substance use, and hopefully all of you will be able to discuss some evidence-based treatment strategies for adolescents with substance use disorder. So it's a lot to cover. So here we go. I love starting with a case. I think this kind of frames things really nicely for why we do this work. And this is a case that I did see in our clinic to protect confidentiality. Of course, some minor details have been changed, but the gist is overall a very real case that I've worked with. So this is a 16-year-old young woman who recently moved to the Bay Area with her family and went to her local pediatrician to establish care. During that visit, she had some complaints of insomnia and fatigue, reported a loss of appetite, and in fact had a 20-pound weight loss on her growth chart. She recently said that she quit her volleyball team and has been really struggling academically. And she did say that she was using cannabis to help with her insomnia at that visit. Her pediatrician at that time diagnosed her with a depressive disorder and did start fluoxetine. Follow up in 2 weeks, she came back to the pediatrician's office and said she was doing a bit better, was less irritable, her sleep was better, and was looking forward to a family trip, but was really worried about flying. So pediatrician talked about some non-pharmacologic options for her anxiety about flying, but prescribed alprazolam and counseled the parents to keep the medication locked and in their possession. 6 months went by, however, and Brianne was continuing to struggle in school, started coming home under the influence, and she eventually told her parents that she has been using opioids that she purchased from friends. And during a private interview, she finally was able to report a 4-year history of substance use that started with her using cannabis, but later came to include nicotine, alcohol, cocaine, LSD, and various prescription medications that she was purchasing from people she knew. And eventually, she was diagnosed with several substance use disorders, including opioid use disorder, cannabis use disorder, benzodiazepine use disorder, and stimulant use disorder. And I think this case just beautifully illustrates how youth can be struggling with some pretty significant substance use and kind of fly under the radar for a really long time. And so I think I'm really happy to be speaking with all of you because my hope is that we can catch these youth earlier and intervene earlier and work together to get them to a better place. So I argue that substance use and addiction is absolutely a pediatric priority. Over the years, addiction medicine has really been very adult focused. When in fact, when we think about things that affect pediatric populations, mental health issues and substance use disorders are the #1 contributors to health burden for this population, right? All of you as psychiatrists see this every day. And when we think about, well, what are the #2 and #3, we see things like injuries and then things like HIV, TB, infectious disease. So mental health, mental illness and substance use disorders are incredibly important. And even for young adults in their 20s, alcohol use is the largest worldwide contributor to disease burden, right? This is across the globe. And in our country alone, almost 1/4 of all deaths can be attributed in one way or another to the use of substances. So to me, you know, I always kind of take a step back and think, what are we learning during our medical education? And we're learning so many important things, but so little focus has been paid to these issues, right? For mental illness and substance use. And so I'm hoping that the culture can change around this. We also know that adolescents are uniquely vulnerable to addictions and are the group that is most likely to experience health consequences, including accidents, dating violence, risky sexual practices, and they're more likely to develop substance use disorders if they are using substances. And furthermore, addiction is a pediatric onset illness. Not only is it important because it affects this population, but it usually starts in adolescence. So if we look at 90% of adults who suffer from a substance use disorder, started using substances before they were 18 and actually developed their use disorder before age 20. We also know the evidence repeatedly and consistently shows that younger age at first substance use is an incredibly strong risk factor for the development of a substance use disorder. So to illustrate this, we look at percentage of people who develop use disorders depending on when they first started using a substance. And this particular study looked at alcohol. So those who delay their first drink of alcohol until age 21, only about 2% of those people will go on to develop a substance use disorder. Now contrast that with someone who started using alcohol before age 14, and look at what we see. Up to 15% of people in that category will develop a substance use disorder. The same can be said for prescription drug misuse as well. So those who start misusing prescription drugs before age 13, 1/4 will develop a use disorder. And we also know that younger age at first substance use infers a shorter time to the development of a substance use disorder. So why is that? Why is adolescence this unique time period, and what makes it so that younger age at first use incurs a higher risk of developing a use disorder faster? Well, let's think about the neurobiology of adolescence. What we know is that adolescents have fully developed pain and reward pathways, but they still have an immature prefrontal cortex. And, you know, to illustrate this fMRI study looking at the pattern of brain development between the ages of 5 to 20, what we know is that brain development occurs from back to front, and that the prefrontal cortex, the part of the brain that's involved in decision-making, future planning, self-restraint, is the last part of the brain to develop. And I think this can be really hard to remember when we're working with adolescents on a regular basis, because, you know, we see these kids and they're bright, they're intelligent, they can do complex math, you know, their processing speed is fast. And so to us, they can seem very adult-like and fully developed. And it's sometimes hard to remember that, hey, there's this really critical part of their brain that is still undergoing so much development. We also know that the adolescent brain has a heightened responsivity to rewarding stimuli, and places a higher salience on immediate reward. And there are some interesting experiments done with this about does the adolescent brain prefer a smaller reward immediately or a larger reward later, right? And the preponderance in adolescence tends to be for that immediate reward, even if it's smaller. So basically, adolescents are primed to look for rewarding behaviors, behaviors that feel good, while their prefrontal cortex really hasn't developed enough to do some restraint on those behaviors, right? So it's, an analogy that I've heard is kind of like a Ferrari with broken brakes, right? It's built for speed, it's built for fun, but the brakes may not be quite there to put a pause on those behaviors. And for those reasons, because we know adolescents are not just small adults, they have really unique characteristics. There's important diagnostic considerations when you're working with a youth who you're concerned about having a substance use disorder. Well, first of all, I think being aware that we tend to under-recognize these disorders and remembering that screening and asking these questions and looking for these disorders is really, really important. And so some of the common validated screening tools that can be used are the CRAFT. There's the S2BI, which is an online screener. And then the NIAAA also has some alcohol-related screening questions. So remembering to look for substance use disorders is really important, because as we saw with our case at the beginning of the presentation, a lot of young people kind of fly under the radar. And unless you ask those questions, they won't necessarily willingly share that information with you. And since this is a talk for a psychiatry crowd, reminding ourselves of the DSM-5 diagnostic criteria for substance use disorders is really important. And I will share my acronym that I created because I love acronyms. So hopefully it might be helpful for all of you. But there are 11 diagnostic criteria for all substance use disorders. Individual really only needs to meet 2 of those criteria to have a diagnosis of a mild substance use disorder. So when I first started learning about this and thinking about the diagnostic criteria, I had a moment of hindsight of, oh my goodness, how many people did I potentially miss, right? Because 2 is not that many. And I came up with my acronym of World Cup match to remember the diagnostic criteria. And here the circles are outlined that. So talking about, are you having withdrawal symptoms? How is the substance use impacting your occupation? And for an adolescent, of course, their occupation is their academics and schools. How is the substance use impacting your relationships? And for adolescents, the most common relationship affected is between their parents or caregivers, right? Using the substance for longer period or in larger quantities than intended, right? Really looking at a loss of control. And I hear this a lot from teenagers where they're like, I started out just drinking alcohol once a month at parties. Now it's become more of like a every week kind of a thing, right? So kind of indicating this loss of control. D is for danger. So is the substance use putting people in dangerous situations? And a big one for adolescents is driving under the influence. We know, and we'll get to this a little bit later, but the number 1 cause of death among adolescents is motor vehicle crashes. And those who use substances and drive are at incredibly high risk. C stands for cut down. So has the person had unsuccessful attempts at cutting down? Urges is also known as cravings. P stands for problems. And this is a big one as well, especially for psychiatry. A lot of folks present with psychiatric comorbidities, and their substance use is likely maybe exacerbating those, right? And they continue to use that substance despite sort of acknowledging or understanding that it may not be benefiting them in that way. But this can also refer to medical problems, right? So is someone fully aware of their liver damage, but they really have lost control of their alcohol use and they continue to use despite that? M stands for more, so this is referring to tolerance, needing more to get the same effect. A stands for activities, so has the substance use kind of crept into your life to the point where hobbies and things that bring you joy are no longer part of your life. And finally, T stands for time, which is, spending a lot of time obtaining, using, or recovering for the substance. So that's my World Cup mat. The CH part is just check the score. So perhaps this will be useful for all of you, but really important reminder. However, when we're working with adolescents, it's so important that, the DSM-5 criteria are not a checklist that you hand to someone and say, how many of these do you think you meet, right? The diagnostic criteria, especially for a substance use disorder, I think are best done in a really conversational way and not as like a checklist and how many, and especially that's true for adolescents. And this is really coming from a developmental lens, right? So looking at those early adolescents where, they're really having concrete thinking, impulsive behavior, right? They may not recognize some of the nuance of, hey, maybe it is my substance use that's impacting my grades right now, right? Middle adolescents, yes, they're starting to develop some more abstract thinking and future planning, but they're still really sensitive to peer and social stimuli, right? And so they may have this perception that, well, all of my peers are, smoking weed or doing whatever, and I'm not any worse than them. So they may also not fully recognize that their substance use is impacting them. And late adolescence, I think, is when most people do start to further develop their abstract thinking and future planning. And personally, in my work, I find that the middle adolescent group, I feel like to me poses a lot more, most of the challenges. I think this group is really sometimes tough to connect with, tough to get in there, often don't recognize that their substance use is impacting them in a negative way. And so my rule of thumb is that I really don't feel confident in making a substance use disorder diagnosis in an adolescent without some kind of collateral. And what we know is that self-understanding is really a developmental milestone in adolescence. And so really relying on that adolescent to be able to fully comprehend and assess the impact of their substance use on their life may not be developmentally an appropriate expectation, right? So really thinking about collateral, asking someone who knows them well, their parent, their caregiver, hey, what have you seen? What do you think, right? And so I think that's really, really important diagnostic consideration. Okay. So I'm going to just look at the chat. Okay, no questions so far. If there are any questions, I'll keep an eye out here. I'll take a little bit of a pause. Excellent. So that was kind of the preamble for why is this important to talk about? What are some of the diagnostic considerations? How are adolescents a little bit unique? So the next part is I want to talk about what are the trends? What are we seeing, right? In terms of substance use in modern adolescents. And for this, I also want to just invite you to learn about the common surveys that are used to assess this, so that if you're ever out there looking for this data, you can be familiar with where to look and where to get this important information. So I'll introduce you today to 3 important surveys that help us assess what's going on with the kids in terms of their substance use. So the first survey I want to introduce you to is the Youth Risk Behavior Survey. This is data from 2019. The survey is done every other year. So again, when you're looking for this data, each survey is done a little differently. So depending on what year you want, you might have to look in a different place. So we'll start here and then we'll look at some of the newer data as well. So the latest data available is from 2019 Youth Risk Behavior Survey, and it looked at high-risk substance use variables and compared that across the past 10 years. And what we're actually seeing here is that substance use among adolescents seems to be on the decline from a historical perspective. So I thought this was really interesting. So the next question, of course, is, well, okay, well, that was 2019. What do we know about what's been happening most recently? So then we go to a different survey instrument. So I'm guessing many of you might be familiar with the National Survey on Drug Use and Health. This is the largest study that looks at substance use across the country. However, the latest results we have are from 2020. So again, we don't have any data here for 2021, but what we see again is similar trends. And here, the gray line is the 12 to 17-year-olds, and the blue is the 18 to 25-year-olds. So these are the populations that I often work with. And what we're seeing here is that cigarette use is at all-time lows for adolescents and declining. Binge alcohol use, steady to declining. So far, those trends are aligning. All around illicit drug use, staying the same to declining among adolescents. So far, two different surveys, 2 different years, the trends are looking promising. So for the latest data, we have to look to yet another survey called Monitoring the Future. So this is a national survey. The latest data is from 2021. So this is the most recent data we have available. And again, the trends are similar. When we're looking at any illicit drug use, numbers seem to be declining, both in lifetime use and past 12-month use. Binge drinking seems to be declining. Cigarette use, all-time lows. Vaping, interestingly, we had some really significant spikes in nicotine vaping in 2017 and 2018. And the latest data shows this, interesting decline, which I'm not really sure how that's going to pan out yet. But overall, we're seeing 3 different surveys, 3 different years, and overall, the trends seem to be promising in terms of youth substance use. So, mission accomplished. We're good, right? Well, not so fast. Although adolescents seems to be using substances less frequently, from a historical perspective, what we still need to remember is that in the US, over 40 million people are struggling with a substance use disorder. So this is a significant proportion of the population. And so this is still really, really important. And this is breaking that down by substance use disorders by age. And again, the 12 to 17-year-olds are in gray. The 18 to 25-year-olds are in the blue. And of note, consistently, the highest rates of substance use and substance use disorder tends to be in those 18 to 25-year-olds, right? So it's interesting for me that they go from some of the lowest in the 12 to 17 to some of the highest at that 18 to 25 age range. So that to me says that this is a really important time period where so many things are happening where these trends are converging. Okay. And yes, adolescents seem to be using substances less frequently, but drug overdose continues to be an important cause of death in this population. So when we break down the top 3 most common causes of mortality in adolescents, number 1 is unintentional injury. Suicide and homicide kind of vie for the number 2 and number 3 position, very sadly. But when we break down those unintentional injury deaths, as I mentioned earlier, motor vehicle accidents are still number 1. But here you can see in the red box, number 2 within that category is unintentional poisonings, which includes drug overdose. So again, that is why we're focused on this and why it still remains important. And drug overdose death rates have been on the rise for this population. This is showing adolescents aged 15 to 19. And the trend seems to be continuing. So this is more recent data comparing 2018, 2019, and 2020 for 15 to 24-year-olds. And you can see the trend here, you know, about 4,700 deaths in 2018 and 2019. And although the 2020 data is provisional, already we're seeing that the number is quite different. And this is true in California youth as well. Here I'm highlighting that the 10 to 24-year-olds, if you compare 2018 and 2020, the percentage of deaths from opioid overdose in that age group went from 9.5% to 15.8%. So this population is having opioid overdose deaths rising at faster rates than some of the other age groups. So again, this is still really important. And why? Well, we know that the synthetic opioids like fentanyl, carfentanil, and similar analogs are largely behind this recent increase in opioid overdose deaths. And just recently in the San Francisco Chronicle, there's this really sad story of a 16-year-old young woman being found unexplainably deceased and thinking that it probably is related to a fentanyl overdose, right? We're seeing this in San Francisco and we're seeing it across the country. I'm just seeing some chats pop up here. Okay, hopefully I'll address some of this as we go. So let's talk a little bit about youth addiction treatment. Because that's naturally the next question is like, hey, this is definitely a problem. What can we do? How can we help? And first, it's important to start by understanding that most people who have a substance use disorder don't get treatment. And this is true across the board for all age groups, right? So, I mean, the 12 to 17-year-olds in this table seem to be doing the best, and still less than 10% of people with a substance use disorder in that age category get any treatment at all, right? And look at the 18 to 25-year-olds, right? We know that this is the group most often affected by substance use disorders. Less than 5% will get appropriate treatment. And this is even true after people present with a near-death experience. So there's this really interesting study in Massachusetts where they looked at all people who were treated for a non-fatal overdose between 2012 and 2014. There's over 22,000 people. Almost 200 were young, 11 to 17. And what they found is that of those young people, fewer than 5% received medication for treatment of an opioid use disorder in the 12 months prior to their overdose. So meaning that it was either not recognized that this youth was struggling with an opioid use disorder, or if it was recognized, these youth were not receiving evidence-based treatment with medication. And even after presenting for a non-fatal opioid overdose, only 8% of adolescents received medication for the treatment of their opioid use disorder in the full year after that presentation, right? Compared to 29% of adults. And the truth is that youth addiction treatment programs are incredibly few and decreasing actually in number. So one study looked at availability of programs between 2003 and 2010. And at that time, less than 36% of addiction programs offered services to adolescents. Towards the end of that survey, towards 2010, that number went down to 29%. And here's a study from 2020 looking at all of the addiction treatment centers in the US, of which there are only 13,585 for the entire country. And only 26% offer adolescent-specific services. So these programs are just really hard to find. And for me, the number that really is really scary is that look at the residential treatment options, right? Only 413 across the entire country. And in California, I think there's 33, most of which are in Southern California. So very few programs offering appropriate adolescent treatment. And what we also know from the study is that those programs that serve adolescents are half as likely to offer medication treatment compared to adult programs. So, I think, as I mentioned earlier, the world of addiction medicine has really been adult focused. I think a lot of pediatric providers weren't getting trained in the recognition and treatment of addiction in adolescents. And I think as such, there has been this lack of a pipeline for providers who are able to offer these services. And now there's this severe lack of programs that can. So thinking about, all of this and how it might be really, really hard to find an appropriate treatment program, there are certain general principles that are important to remember when we're thinking about addressing adolescent substance use. And so if you're out there and you're, in your practice, you're seeing an adolescent for the first time, you're worried about a substance use disorder, where can you start, right? And so I think number one to remember, if someone has kind of a mild to moderate substance use disorder, the most important thing you could do is assess for immediate danger, right? And again, for me, are they driving under the influence, right? Are they injecting drugs? Are they using synthetic opioids that put them at risk for an overdose death, right? These are the most important things to assess for. And feeling confident and comfortable providing a brief intervention with a clear, concise message that the healthiest thing they can do is to not use substances, easier said than done. And of course, employ your brief motivational interviewing at this point, right? And work towards facilitating behavior change by helping the youth resolve ambivalence, your basic MI. But please schedule follow-up to assess progress, right? So many times I've seen an adolescent come in to see their provider and they notice something that's concerning and then they say follow up in a year, right? We can have them come back sooner. We can check in, we can see how they're doing. We can see if things are progressing in a direction where it's becoming dangerous. So please remember to follow up with these youth. And for those youth who you're really worried about and thinking that their substance use disorder may be in the severe category, similar, assess for danger. And here, your brief intervention should really focus on referral and treatment. And these are the youth where you might strongly recommend or discuss involving a loved one or a parent, guardian, caretaker, etc. And perhaps in these circumstances, you might consider even breaking confidentiality, right? So this is where it becomes really challenging, really complicated. But if you are really worried that a youth is at risk for overdose death or they're driving under the influence and you're just really worried that something bad will happen to them, I think this is a consideration about who else can you get involved in their life. And what we know is that most youth will benefit from a combination of medical and psychosocial interventions, right? Not surprisingly. However, what I've often seen with adolescents who are using substances is that there tends to be this knee-jerk reaction of, oh my goodness, they're using substances, send them away somewhere, right? Send them to Utah or, et cetera, insert state here. And what we really need to remember is take a step back and think about the fact that the level of care should be chosen on individual needs and should be the least restrictive possible. And so, I firmly believe that many adolescents can do really, really well with outpatient level of care. Some may require inpatient care, and that's fine, but I really want us to step away from that knee-jerk reaction of sending people to residential addiction treatment just kind of because it's the Gestalt. So when we're talking about psychosocial interventions, what are the evidence-based options for adolescents with substance use disorders? So some of the things that have been studied include family-based treatments, behavioral therapies, cognitive behavioral therapy, of course, motivational enhancement therapies, 12-step programs, as well as therapeutic communities. And you might be asking yourself, well, like, which one of these do I choose and when? And so I looked to this study from Tanner Smith from 2013 that actually did this really interesting comparison of treatment modalities and compared them to a no treatment control. And off to the right are the treatments that seem to be the most effective. So here's no treatment, group mixed counseling, practice as usual, may have some benefit. More effective options might be the motivational enhancement therapies, CBT, behavioral interventions. But this paper really found that family therapies seem to be the most effective in addressing adolescent substance use in a statistically significant way. And I've really seen that to be the case in my practice as well. And so if you're wondering what to recommend, I think going with family therapies is always a good evidence-based option for those psychosocial interventions. In terms of medical interventions for youth addiction treatment, there's a couple of things we can offer, including clinical monitoring, drug testing in a really non-punitive therapeutic way, outpatient pharmacotherapy for addiction, and potentially medically supervised withdrawal, depending on which substance we're discussing. And I really want to highlight today treatment of opioid use disorder for adolescents. Given the very sad statistics of increasing mortality rates, the rampant presence of synthetic opioids that are contributing to skyrocketing deaths due to opioid overdose, I really want to highlight this with all of you today. Because the bottom line is that medication treatment for opioid use disorder saves lives. It improves patient survival. It also helps people stay in treatment longer. It decreases criminal activity, increases patients' ability to get back to their occupation, and improves birth outcomes for women with substance use disorders. And looking at what are the options for opioid use disorder treatment, there are 3 medications that are FDA approved in adults. The first is methadone. There's buprenorphine naloxone, as well as extended release injectable naltrexone, which lasts for a month. So you may have heard of some of these. Of course, methadone is delivered really at methadone treatment programs, highly restricted, highly regulated. Whereas the other 2, the buprenorphine and the naltrexone, are medications that you can provide in your practice. So what do we know about these medications in adolescents? Well, looking at buprenorphine naloxone, so buprenorphine is a partial mu opioid agonist. And although there haven't been many studies on this specifically with adolescents, there were enough studies that it did gain FDA approval for treatment of severe opioid use disorder in adolescents that are 16 of age and older. And I often have colleagues ask me, well, what if you have a 15-year-old who has a severe opioid use disorder? And I think, this can be a difficult discussion, but certainly this is something I would consider using potentially, depending on all the factors involved. Methadone is a full mu opioid agonist. And unfortunately, there really aren't any controlled trials in adolescents to support or not support treatment with methadone. There has been a literature review of 9 studies showing that maybe adolescents will have higher treatment retention rates if they're treated with methadone. However, I find that methadone for adolescents is really quite inaccessible. As I mentioned, methadone can really only be delivered in federally approved methadone treatment programs. And per those regulations, an adolescent under age 18 really needs to have proof that they've had 2 prior treatment failures before a methadone treatment program will accept them. And my experience has been is that most methadone treatment programs find that to be a lot of paperwork and a lot of sort of federal approval. And so I really haven't had anyone under 18 that I've known enroll in a methadone treatment program. And finally, speaking of naltrexone, this is a mute opioid antagonist, so it blocks the effects of opioid medications. Again, no controlled trials in adolescents, and therefore not FDA approved for people under age 18. However, some studies have happened, hopefully will continue happening, that have shown promising, promising signal that it may be helpful for adolescents with opioid use disorder. Practically speaking, again, I have never been able to get naltrexone off label to a person under age 18. So this will be interesting to see how it evolves. So as I mentioned, we're going to, this talk covers a lot of ground, and I want to make sure that we have enough time left for some questions and discussion. However, I also want to introduce to all of you the program that we were able to start, the UCSF Youth Outpatient Substance Use Program. So this is a program that's based and embedded at the UCSF Adolescent and Young Adult Medicine Clinic, currently at Mount Zion, but slated for a move to Pritzker Building with all of you fine folks in April, hopefully. So we started YOSUP in 2019, recognizing the dearth of adolescent-specific addiction treatment programs, and really feeling stumped as to what to do and how to help these youth. And what do we do? So we provide services for youth up to age 25. We can do the assessment and diagnosis of a substance use disorder. So a lot of pediatric providers don't feel comfortable with that. They're not really sure, they don't have enough experience or training. So even if someone is referred to us just to say like, hey, does this kid have a substance use disorder? Like, we can do that. We provide a lot of education on substance use and addiction. We work with parents and caregivers about, safety, risk reduction, what can you do? How do you develop a behavioral agreement? Things like that. Currently, in terms of individual therapy and things like that, we're providing referrals for therapy with hopes of getting a psychotherapy program up and running over the next couple of years. We also provide referrals to higher level of care when appropriate. And we do a lot of case management, facilitating collaboration between community agencies, getting youth hooked up with services if we can't provide those services, et cetera. Naloxone, we talk to youth about naloxone for opioid overdose reversal. We do provide outpatient withdrawal management. So for youth with alcohol use disorder, for example, most youth are at very low risk for complicated withdrawal, and so can be safely managed with outpatient medications. And so we can provide that as well. And of course, we're providing medication for the treatment of substance use disorders, including buprenorphine for the treatment of opioid use disorder, as well as some medication treatment for co-occurring psychiatric disorders. So I think, we try to be really careful about not overstepping our bounds with this one. Certainly if someone has, co-occurring depression or anxiety, we feel pretty comfortable with that. Other disorders, bipolar disorder, psychotic disorders, we of course try our best to refer to qualified psychiatrists for those. But as you all know, that can also be challenging in this time of the pandemic, as a lot of psychiatric providers are overwhelmed. We do a lot of risk reduction strategies. We can provide risk reduction equipment. And of course, we can offer urine toxicology monitoring in a really non-punitive, therapeutic, supportive environment. So, for more information, you guys, can check out our website. Feel free to send us some referrals. reach out to us. We'll be happy to provide some case consultation or see your patients. And I think, oh, yes, we have, I was eager to have some time for questions. So that is what I have today. And I'd love to take your questions. So.
Fantastic. Thank you so much. So starting at the very top, if I'm managing this well, Jessica, if you're still around, you could go ahead and unmute yourself and ask your question.
I don't know if my audio is working. Can you guys hear me okay?
Oh, yeah, I can hear you.
Okay. Yeah. Basically, I was just asking about privacy and confidentiality concerns when adolescents are sharing information about their substance use. And I wanted to hear a little bit more about that, Veronika, about what are the actual practice guidelines around that? And if you could say a little bit more about the nuances for when you decide that you're going to break that confidentiality.
Yeah, thank you so much for that question. So I think there's a couple of different buckets to address here. So one is, what can adolescents access in terms of treatment without parental involvement? And two is really like disclosure and, record release, things like that. So in California, adolescents are able to access psychosocial treatments and some medical treatments for substance use disorders. And this is 12 and up. So under 12, technically is not protected under the law, but 12 and up, so can come to my clinic and say, hey, I'm struggling with this. And I can provide them counseling, motivational interviewing. I can, do their general health care without parental involvement. They can also start working with a psychotherapist without parental involvement or consent. However, prescribing medication, so psychotropic medication, or this includes medication for addiction treatment, that does require parental consent. So for the youth who are struggling with opioid use disorder, who want to start buprenorphine, for example, under the law, I'm unable to do that without parental consent. So that's sort of what can they access. In terms of disclosure and how do you work with families and what can you share and what can you not? Certainly substance use and mental health is protected by the law in California. And what California requires is actually written release from the youth to be able to share that information with anyone, including a parent or guardian. So I think this is really important. Now, the interesting thing for our program is, I would say the most common way that youth present to our program is through parental facilitation, let's say, right? So oftentimes what happens is that the parent kind of drags them to our program. And at that point, we have a conversation about, if this is something you want to pursue. We usually want to work with the family, and the kid would really need to be in agreement about signing a consent to say that we can work with the family members. And most of them are okay with that. We have had only about 1 or 2 cases where the youth present really with not wanting any parental involvement. In fact, don't want their health insurance used for these purposes for confidentiality concerns. And so for that particular youth who resided in San Francisco County, we were actually able to sign them up for Medi-Cal minor consent, which basically gives them their own Medi-Cal account that they can access sexual health, mental health, and substance use services under. And completely just bypass, the parents' health insurance, et cetera. The interesting thing about, the one youth that I'm thinking of in particular is the way we approach it is listen, we are happy to provide you confidential services, but what I'm hearing is that it's rough being at home. And could we help by actually educating your parent about what you're going through and helping them learn how to best support you, right? And over time, this kid that came to us using Medi-Cal minor consent, now she brings her mom to clinic, right? And they're having a much better relationship. So this is often kind of an evolving thing. And, trying to encourage parental involvement whenever is feasible and appropriate is what we try to do. There was another part, Jessica, that you asked about, the breaking confidentiality. Yeah. Okay, so this is a really tough one. And what I do in order to avoid implicit bias is to set some rules for myself that apply across the board. So for me, if someone is operating a vehicle under the influence across the board, I just told myself, hey, this is the #1 killer of adolescents. I'm worried enough about this kid that to me, I'm going to break confidentiality. And I apply that rule across the board. Youth who present in sort of less clear cut scenarios. So say, you're working with a youth, they're just starting to use, I don't know, let's say, benzodiazepines. They're not at immediate risk for, an overdose death, that you've been able to determine. And they're like absolutely adamant that they don't want parental involvement. This is where follow-up becomes really important, right? So I say, sounds good. I hear you. I'm going to respect your confidentiality, but I'm really worried about you. Let's have you come back in a month. Let's just see how you're doing, right? And I would think that, over time, if I saw that kids' behavior is escalating, or, they're putting themselves in more dangerous situations, or, physical and mental health issues are starting to get worse, I'm going to have a conversation with them about when is the right time to involve a family member and consider breaking confidentiality. So it's a gray area. One thing I will say though, is it's never wrong to suggest it. It's never wrong to say like, hey, I'm worried about you. I think it'd be really helpful to involve X family member. What do you think? Right? Like you can do that at any point. They can say no, but a lot of them actually say yes. So it's never wrong to ask.
Thanks for that, Veronika, and thanks for that question. Piggybacking on that, Shelley, if you're still online with us, you could go ahead and ask your question.
Great, thank you. So I have a 15-year-old who's chronic marijuana use, has binge drinked, has tried LSD, and wants to stop, and mom is involved. The therapist says, all right, we're at a point now, just stop all drugs. And I'm like, well, there is this thing of like harm reduction, and if he cannot do it during school days, because I don't know what coping skills he has and that. And I said, but I'm not the expert. So I know he's going to the drug program, UCSF, soon. So maybe they can answer your question.
Okay, I love this question. So what, this is a tough one because we get this all the time, right? Of like, well, what about this one, but not that one? So what we know from sort of the literature and the studies is that it seems to be most effective that if you're working on substance use disorders, to address all of them simultaneously. And to me, thinking about neurobiology kind of makes sense a little bit, right? If you're using something to activate that reward pathway repeatedly, right? Like that's going to facilitate the ongoing addictive process, right? That reward dopamine hit. And so to me, it does kind of make sense that if you're going to work on substance use disorders is to really let that reward pathway kind of cool off, take a step back, let it reset, let it get back to equilibrium. And so to me, it does make a lot of sense to sort of address everything at once and kind of rip off the Band-Aid. That's, easier said than done, but I think is supported by sort of neurobiological studies. I also, I hear a lot about like harm reduction and the way that term is used, right? I sort of feel like in the lay public, that term has been like overused a little bit for like, I'm going to let you do what you want to do. You know what I mean? Like, so I think we have to be really cognizant about what we're calling harm reduction, right? So in terms of opioid use disorder, harm reduction is like, I'm not ready to stop injecting. So you're going to give someone, clean supplies to prevent death. I just, I have a hard time saying that like, allowing you to continue using drugs because you want to is like technically harm reduction. You know what I mean? I don't know. It's a hard definition. It's more of like it's a harm reduction in a way of like, it's going to be easier for us because you're going to keep doing what you're going to do. So it's kind of like harm reduction to the provider.
Thanks, Shelley, for your question. Thanks, Veronika. Christina Benke, you had a question about intentional overdose versus accidental. Are you still here?
Yes, I'm still here. I think I was just curious because I was really just soaking in the data that Dr. Mesheriakova was presenting, and I was curious about two components. One, the kind of the breakdown of primary drug cause for overdose, and the other piece being it was a distinction made between whether or not the overdose was accidental versus intentional. Because I know that a lot of emergency rooms and ICU see a lot of Tylenol overdose as well. So I'm just curious about the data on those.
Yeah, it's tough. The way the data is collected across the country is a little bit eclectic, depending on which region, which county, how is the data being looked at? Is it collected post-mortem? Is it, at what point? So I think there's a little bit, I think it's probably in many cases difficult to ascertain, ultimately accidental versus intentional. However, for those youth who are presenting to the ER, obviously who, survived their overdose, I think that becomes a really good question. And how that data is reported, I'm guessing is probably also a little bit eclectic, right? Depending on which diagnosis codes are entered and how they're pulled. I think it's a really important distinction. And I think that there's probably could be made improvements in sort of distinguishing those. Yeah.
Thanks for that. And shout out to Caroline for answering some of the more the basic questions. So thanks so much for monitoring the chat for me. I really appreciate it. I do have a question about eating disorders and substance use. So that came up in your case, and kind of where things sort of started potentially. And do you have any recommendations for how to treat a pretty significant eating disorder and a significant substance use disorder? What choices do you make there? And I know probably there's differences between anorexia nervosa versus bulimia versus binge eating, right? So I would love to hear your thoughts about that.
Oh gosh, I love this. Yeah. So interestingly, there's a couple of thoughts that come to mind. One, there's a population of kids who get directed to our eating disorders program, billed as eating disorder diagnoses because of significant weight loss. And we see them and we're like, it's definitely not an eating disorder, and it's chronic cannabis use causing profound appetite suppression and weight loss. So there's a population of kids who we see that are like this. The other, sort of one end of that spectrum is also the kids who are coming in with cannabis hyperemesis syndrome and have weight loss because of that. Then there's the bucket of, someone has bulimia nervosa and a co-occurring substance use disorder, which is really well described and thought to have some similar psychopathology with impulsivity, et cetera. And I'm going to hold that thought for a moment. Then there's another bucket of anorexia nervosa, right? And what I'm noticing is that the category of atypical anorexia nervosa seems to have slightly higher preponderance of people struggling with substance use disorders than people with just, run-of-the-mill anorexia nervosa, which is really, really interesting. I tried to do a lit review on this, and there's nothing out there yet, but this is just kind of what I'm seeing. And this gets really tough. So the way we sort of strategize is like, what are the things that are most likely to cause you mortality? Right. So for people using opioids and are at risk for opioid overdose, we really need to prioritize treatment of that disorder before we can address an eating disorder really meaningfully. If someone has, something that's not likely to kill them, like a cannabis use disorder, something that may be problematic, impacting their life, but they're not going to overdose and die, then we really have to focus on anorexia nervosa, just knowing the mortality rates for that particular disorder. And honestly, for a lot of our youth, the prioritization of which disorder to address when tends to shift over time, right? Sometimes one peaks, the other one, decreases. So it's a tough equation, but it comes down to like, what's going to be most deadly in the moment.
Appreciate that. Risk analysis, what it comes down to, right? Appreciate that. I'm looking at the chat. We have, less than a minute left. So we have lots of questions about the clinic. So it's very exciting. You're gonna get lots of referrals. And anything related to, Christina, you had a lot of questions, and feel free to, oh, it's 1 o'clock, darn it, I just did that to you. I'm so sorry. I didn't mean to dangle that in front of you. We are out of time. And it looks like you have some great resources in Veronika and Caroline for learning more about USUP and their programs. This is so exciting. Thank you for giving us a lot to think about. Thank you to all of you for participating today. Have a great rest of your afternoon. And thank you so much, Veronika. Bye.
Thanks so much, everyone. Bye.